Good afternoon and good morning to everyone. Thank you very much for joining us. My name is Matthew Broham. Today I have with me three very talented and experienced panelists spanning collectively, I won't tell you how many years, but I can tell you that they're spanning 9 time zones today. And we're here to discuss the topic dear to many of our hearts in the HTA community is like, well, we're prioritizing COVID-19 technologies. So how is that affecting HTA processes and assessments more generally? And how might it affect these processes going forward? So today's format is going to be a panel. We're going to hear from each of our panelists for about 10 minutes, and then the panel is going to be given the opportunity to ask the speaker some questions for roughly 5 minutes. And towards the end of the presentations and that format, we'll turn to the questions that the audience have posted, and I'll ask those of the panelists as well. So starting in or presenting, introducing our panelists in the order in which they're going to speak, and we're doing this from east to west, as it turns out. So I have Inaki Gutierrez Ibarlucia. He's the Director of Innovation at BioF in Spain. He's coming to you today from Bilbao. He's also the current president of HTA, and if you want to look at his other experiences and qualifications, I please ask you to look at the information that has already been posted on people's bios. Second up, we've got Michelle Majumdar. She's the Director of Scientific Affairs at CADTH and based in Canada. She's here where I am in Ottawa currently. And among her experience, she's spent close to 2 years seconded to UNETA, serving there as the Senior Scientific Officer. So she brings with her that experience as well. And lastly, our third speaker is Lou Garrison, topping it off in the West over in Seattle. He's the Professor Emeritus at the School of Pharmacy at the University of Washington. And he also has a wide range of experience, and I'm just going to mention one of them, and that is he's been the past president of ISPOR. So we have a wide range of panelists with wide set of experiences and talents, and so I'm going to hand it over immediately to Inaki to kick us off and get us underway.
Yeah, thanks Matthew for the presentation, and thanks Tara also for giving me the chance to speak about what is our experience around fighting COVID in a case. First of all, as a disclaimer, I do need to say that my opinions are based on my own opinions, not neither are the opinions of HTA or in the case of BioF, that is the Bas Foundation for Health Innovation and Research. So how we felt around COVID, and I think I felt at the very beginning as Alice in Wonderland's rabbit, and we were encouraged to go fast, and it was something that started in December in China, in Far East. But that was we at the very beginning thought, well, it is nothing that will happen in our case. So, but it was late February, that we discovered that it could happen also to us, and it was just in a couple of weeks that our hospitals were superseded, the EQ units were overwhelmed, and so on. So also from the side of the HTA bodies, it was also a feeling that we need to go fast in terms of giving information and evidence to our health systems, and also providing some recommendations on how to act. On the other side, the main aspects that have affected the HTA was the lack of faint evidence that we had, because we were fighting against a new pathology. Also infoxication. So this lots of information coming from different sites, not good evidence, to be honest. And so it is, we receive evidence, we would say information coming from different sites, and it was good that also editorials and journals and so on, they put all the information in open access. But on the other side, it was a lot of information coming from these different sites, and it was difficult to differentiate which was good and which was not so good. And on the other side, it put into place that the regulatory and HTA mechanisms were not prepared for pandemics. Those are the main aspects. On the other side, we as HTA bodies, we were accustomed to evaluate drugs, medical devices, sometimes public health interventions, but are not in general going on topics like symptom analysis, groups at risk, vaccines, disinfection agents, personal protection equipment that were part of the things that we were in need to evaluate. On the other side, there were other technologies that we were started evaluating, but we were not accustomed to evaluate at all. So like apps or artificial intelligence, and those were related, for example, to contact tracing on infected citizens and so on. So those were aspects that were related also to something that we were not accustomed to. And also, finally, there were modeling for planning around bed needs, EQ units, and so on, and they were used also for planning in the healthcare systems. And I need to say that we were not accustomed as HTA bodies to evaluate them. And that is something that we need to think about and reflect. On the other side, I need to say that the regulatory mechanisms were not prepared for pandemics. In fact, regulatory bodies felt overwhelmed with petitions, especially from medical device companies and also innovators on personal protection equipment and those that were inventing new agents for disinfection, or even some medical devices that were linked to disinfection agents and so on. On the other side, it was seen that there was a lack of coordination with HTA bodies in some senses. I think in the case of drugs and in the case of in some cases on medical devices, there was at least a mechanism that was finally structured. But in general, in the case of personal protection equipment and for example, disinfection agents and also in some specific medical devices, that was not. We were in need to jump on some of the aspects because regulatory bodies did not respond on time. So we were in need to also to give answers on regulation to our governments. And finally, it was stakeholders' involvement because of being locked down. It was quite complicated. So we need to say that it was not established mechanism in terms of enabling stakeholders' involvement. Finally, regarding the regarding one slide before. So regarding the approval and launch delays of new technologies, well, that could also the approval and launch of new technologies could be delayed, and that is because of remote work that affected in-person meetings, and especially in the case of regulatory bodies. Also in the case of ethics committees, that they were under-resourced, as many members were or are clinicians, public health or allied health professionals. And there was also, I could say, especially in the case of patients, there was an underrepresentation because of, I could say, digital gap. FDA and EMA have reported delays in approvals, and I don't know to which extent because of this new pandemic landscape. I don't know if perhaps PROMs and PREMs will be differentially considered, and that is a question that perhaps we can bring to the audience. But in principle, in some of the cases, at least PROMs were used in terms of deciding on which technologies, especially drugs and medical devices, to be used in terms of fighting against the pandemic. In terms of the new regulations, at least in Europe, there was also a delay in the publication of the European Medical Device Regulation that was supposed to be implemented in May. But even the European Union has decided, because of fewer resources, has decided to delay the implementation of the regulation. Also, there was an urgent need for the industry to focus on COVID-19, and even the European Union also have put many calls around COVID-19 that have been put in place in just one month or a couple of months. And on the other side, it was funny because one of the things that was related also to the pandemic and the use of medical devices, the medical device regulation included more rigorous requirements on medical devices and more clinical evidence for market access. And during the pandemics, we have been with faint evidence and not much information that justify the recommendation on inclusion or not. Regarding the balance between evidence and uncertainty, well, most of the HTA bodies, we have done rapid assessments, but it was a lack of high quality evidence, and it was a chance for real world data, and we have used real world data as the pandemic was advancing. Also, we have been working in the co-design, especially public-private interaction, and it was true that many HTA bodies, what we have done, it is free scientific fast-track advice for companies developing novel diagnostic, therapeutic, and digital health technologies for COVID-19. One of the things regarding uncertainty is that in this case, one of the challenges, especially for market access and also for health systems, it is, should that affect price negotiation? So in terms of pre-commercial procurement and public procurement of innovation, that is another thing that we can discuss. Regarding priorities, well, priorities and methods of working could have changed, probably because companies' engagement with healthcare professionals will change, especially because of current interpersonal distancing rules, and also how healthcare professionals engage with patients. And nowadays we are talking much more around remote work and also perhaps digital health. And also, depending on the extent of the pandemic, it would be a stronger push to deliver care at home, use digital technologies, local solutions, and local production, and also the outcomes. It could affect also the outcomes to be considered, as mentioned before, regarding PROMs and PREMs. Another thing that has happened during the pandemic is the new HTA definition that establishes that is HTA is a multidisciplinary process that uses explicit methods to evaluate the value of a health technology along its life cycle. And another thing that was put in place was that the HTA is to produce and sustain a healthcare system that is equitable, efficient, and of high quality. Furthermore than that, establish also the dimensions and the life cycle concepts, including dimensions like ethical, social, cultural, and legal issues, organizational. But one thing that I wanted to I would say add, it is environmental aspects. That environmental aspects will be very crucial in the future as a pandemic has put in place, especially with the masks, gloves, and other personal equipment that have been thrown to the environment, and also local production that have been pushed in comparison to production that comes especially from Far East, and also the concept of life cycle in terms of deciding on technologies to be included. Much more than that, there has been a discussion around value, and that it was included in the definition, that the overall value should be taken into account the perspective taken, the stakeholders involved, and the decision context. So that reinforced the role of local HTA analysis in terms of the introduction of technologies. In terms of what we have done so far in the case of the Basque Office for Health Technology Assessment, that is the HTA body that I represent, we have been in principle in the past we were focused on diagnostics and treatments, but during the pandemic we have been working in much more in other type of technologies, like the analysis of organizational models. We were involved in the BAS modeling task force. We were involved in the co-design of the local app that is called COVID-19, and also in the contact tracing design of the app, and also in personal equipment, personal protection equipment like masks, combs, gloves, protective screens, and validation. And finally, what are HTA bodies, and with this I finish, what HTA bodies will need to change. First of all, that technology is not the, I would say, it's not, it's a catalyst, but should not be the focus. And it seems to be that in some cases, technology has been put as the focus. And I think the question to be solved and the outcomes to be changed are first, that we need to be more proactive. In the past, we have been quite reactive in general. We need to be much more tailored to the context in terms of the local production and system need, and also in terms of working together with innovators and companies. New priorities or all new ones. So that means thinking about broadly about what are the needs in reality in our systems, and we need to be closer to regulators, innovators, and providers. So and there are challenges to include patients' voice, especially if we are thinking about the new normality. And finally, be aware of the new HTA definition. And I think it is done. I think I'm a little bit late, so I'm thinking.
Oh no, that's all. Yeah. We're good. So you basically found yourself in a position having to review technologies that that you hadn't been used to reviewing. You had to do them faster than you perhaps used to doing in the past, with less information. What happened to the other technologies? Did you get more resources to help you continue with those other technologies, or did some of those technologies that you would be looking at normally, did they get put on hold, or did they come through the door at a slower rate? And was there any thought to giving you more resources to perhaps gear you up to be able to deal with essentially an influx of questions around health technology assessment?
One of the things that have been put in place, it is the importance of early advice and early dialogue with companies. That was one of the things that the pandemic has put into relevance. Regarding the priorities that we had before the pandemic, it is true that in some cases there has been a slight delay in the process of evaluation of the technologies that we were supposed to evaluate along this year. So probably that will affect also recommendations. At least it has happened up to June. Nowadays we can say that we have a delay of 1.5 months, more or less, and that could affect also recommendations in terms of being included in the benefit package at the Spanish level. But it has happened overall. I don't know how that will affect also companies, but probably companies will be affected in this sense because of this delay. But on the other side, in terms of resources, I think it has brought to the governments that HTA is more needed than before, and especially it has put into relevance the need of what I said before, the need to private-public coordination, and much more work on I would say market access, and especially co-design and related to the needs of the systems. I think those are the most important aspects that I would rephrase, or I would highlight.
Right. Just wondering, other panelists, if you have a question you want to ask, we've got a couple of minutes. But if I see a video appear.
Yeah. Inaki, thanks very much. It's really good to hear. This is Lou Garrison from Seattle. Good to hear what's happening in the trenches. I'm not in the trenches with you. I'm locked in my home. I wonder about, we've had this concept of HTA focusing on the healthcare sector, but obviously a lot of these decisions are affecting education, criminal justice, the much broader concept, of society and a very broad societal perspective. So how are you analyzing, say, the situation? How do we return to school? How do we return the children to school? As it becomes a health technology question, how do we deal with that? Or how are you guys thinking about it? Yeah.
Well, the good thing, at least in my case, it is that one of the units in my foundation, it is regarding organizational innovation. So we have been also helping the government on regards of those questions, especially being back to school. It is true that we don't have the crystal ball, but at least we have been analyzing the different facts, and probably we will be need based on some of the proposals that we have done so far and test. So we don't have the solutions, but at least we have provided to the government some insights of how to act in terms of being back to being back to school in our case in September, and those are based on probably giving more space, especially protective measures, and also trying to go with some kind of epidemiological vigilance. So those organizational aspects have been also analyzed by us and provide some recommendations to the government. But it is true, it will be difficult because we don't have the evidence that justified a recommendation or other.
Yeah, no, it's I mean, but it does illustrate the broader concept of technologies, organizational structure, and as a technology. So yeah, that's a good.
Thanks for that. So I'm going to pass it off to Michelle now. So we'll disappear once Michelle's here. Here we go.
See if I can advance this. Well, thanks very much, Matthew, and thank you to Sitara for the invitation to be part of this webinar. I'm looking forward to the discussion, some good questions already. I do have a couple of disclosure slides. This one's for my organization and the next one's for me as an individual. In the interest of time, I don't think I'll go through them. However, they're going to be available. I think the slide deck's going to be available, or at least the recording is, so I'll bring up the next one just so you see it as well. Apart from me being employed by CADTH, I don't think that there's any of my activities that represent a conflict of interest, but you'll have those for your own assessment. Okay, so today I'm going to share how CADTH has responded to the COVID-19 pandemic, and hopefully this is a really nice follow-up from Inaki's contribution, which did a wonderful job of outlining some of the common issues or challenges that HTA agencies globally are facing. I'll try to focus my time on COVID-19 specific activities, but I did want to take some time to explain what taking on this new work has meant for regular CADTH business and for our staff. So I think I'll start there really with our people, because we often say that our people are our greatest asset at CADTH. And I'd be remiss if I didn't take this public opportunity to thank my team specifically, but the CADTH team more generally for all that they've done during this uncertain time. We've been lucky at CADTH that we made the shift to working remotely with relative ease, but certainly the CADTH team have had to deal with, extra pressure in their personal lives, as we all have, and we wouldn't be able to support Canadian decision makers and the stakeholders without such a committed CADTH team. So I wanted to take this opportunity to publicly thank them. And it's really because of the commitment of the CADTH team that we've been able to maintain, I'd say, relative business continuity in most of the parts of the organization. So unlike some HTA agencies, we haven't had any disruptions with our single technology review processes, so the Common Drug Review and the Pan-Canadian Oncology Drug Review. Our expert committees have shifted to meeting virtually. We had some experience with this before, so that happened with relative ease or minimal growing pains. But we have recognized that this isn't business as usual for everyone, and in particular, say for the patient groups. I oversee patient engagement at CADTH, and patient input to our drug submissions is integral. So, we have heard that patient groups, some of them are struggling to meet some of the timelines for making that input, and so our patient engagement team has worked with patient groups where that's necessary to, for example, provide an extension. But business continuity wasn't possible across the entire organization, and it was needed to sort of make some difficult decisions and pause some programs and some projects. And one of the programs that did get paused was one that I'm responsible for, the CADTH Scientific Advice Program. When we were pausing some of the projects and the program, we really needed to consider a number of factors. So what were the priorities of Canadian CADTH customers? So, provinces and territories. were quite preoccupied with COVID, so maybe they weren't that pressed to make a decision on other health technologies. We also had to be mindful of the availability of clinicians to participate in some of our projects. And we also needed to be aware that some of our staff might be needed to work on COVID-related activities. So that was really our non-COVID related work, or our regular business. So now I'll shift to tell you what we did with respect to COVID-19 related work and what we're still doing. I think what was helpful was that at the beginning of this, we received very clear messaging internally that COVID-19 was our top priority. And this was important because it helped frame our response, and it helped us to prioritize. So for example, making those tough decisions of pausing a program or putting projects on hold. We established an organization-wide team known as the COVID-19 Core Action Team. It's still in place. So a broad group was convened to discuss cross CADTH matters. So this could be communication, internal and external. Our website, we developed a COVID-19 microsite, various webinars that we've delivered, and various things like that. This group met twice a week. It's currently meeting once a week. But we also had this subgroup, this smaller group that was formed, which looked at incoming requests. It was called a triage group. This group met daily for the first 2 months, and it's currently down to meeting twice a week. And daily seemed like a lot. I was on this team, but it really, this sort of frequency helped support the responsiveness that was really needed by our customers who were submitting those requests and needed answers to their COVID-related questions. So when I mention these topic requests, I'm really referring to our reactive work in the COVID space. And this was and is very much based on incoming requests from CADTH customers, but I would say also our stakeholders, which is something different and not something that we typically do. So those with a health technology related COVID question are encouraged to submit their query via web form. That request is then discussed at the next triage meeting, so usually the next day. And if it's decided that it's going to move forward, then a literature search is done, for example, a report is produced. What we also did was, some of the reports took the form of, say, rapid response, which is something that we do, several hundred of these a year. But some of these required more of a custom product or a custom service. And it was real huge variety in the requests that we received. It was everything from comparative effectiveness of various types of aero chambers, cardboard or plastic, effectiveness of internet-based mental health interventions, to any information we can find on how provinces and territories may resume services that were paused because of COVID. So, speaking to some of the thoughts that Inaki and Lou raised about sort of having to, work beyond the scope of what we're traditionally used to, that became standard and sort of a daily practice, sort of stepping outside certainly of our comfort zone. Alongside of this, we were working up topics proactively, and here I'll focus on the proactive work that we're doing in the pharmaceutical space, because there are a number of activities. We've been monitoring ongoing clinical trials, and it's really, for example, sort of various antivirals, and it's really to get a better lay of the land. It's quite overwhelming. We get literature searches sent to us, daily searches from our information specialist team, but obviously we're sort of monitoring news outlets and journal sites, and it's a vast amount of information. So we really needed to have a focused approach to what do we need to monitor and what do we need to be, so we can be prepared for what may come to us in the future. We also created a new type of report for our evidence reviews, and we piloted this with our evidence review for remdesivir. This report is a living document, or an evergreen document, we're calling it. And we haven't done the sort of living document before, although now we've done several of them in the COVID space. And it was because COVID really necessitated this. The evidence is evolving, and we needed to ensure that our reports are being updated. So the remdesivir report, for example, has been updated several times since first being published as new data becomes available. And I would say in terms of a scientific report, this is quite different for us. You're relying on only published data. We're used to not having to do that necessarily in the drug space. And I thought this is my last slide, and I thought I'd just close by sharing some reflections. It's certainly been a time for learning, but there have been some challenges that we've learned from. We've had to learn how to manage the hype, and there's been a lot of hype. We've been encountering publication by press release seemingly all the time. We've had to figure out what we were going to do or what our position is with respect to preprint publications and how to manage those. Very early on in this, one of my colleagues sort of inspired me, I guess. He's a frontline physician, and he said, I see there's a real opportunity for CADTH to have their place being the ability to cut through the noise. There's so much noise out there, so can CADTH cut through the noise with clear messaging on the evidence? And that's really been my motivation throughout. So, how has CADTH responded in short? We've always tried to be quite nimble of an organization, but, COVID has pushed us. It's made us had to pivot. And, again, we try to be proactive, but, we're sometimes busy with reactive work on what's on our plates on a daily basis. But it's really forced us to create space to be anticipatory and to be prepared for what's coming. But one thing that I don't think has changed is our commitment to quality and the rigor of our scientific assessments. And certainly we know that there's going to be uncertainties that will need to be managed downstream. But like the entire system, CADTH has had to adapt during this time. And I think what will be interesting to see what lasting effects COVID has on CADTH, but also on HTAs in general. So thanks very much.
Left myself on mute there. Thanks, Michelle. Very useful. I'm going to pivot myself with a question to you that's perhaps going a little beyond what you've looked at here. But I see it. I feel it myself as an economist. I see it in other people's writing around the world that essentially we may end up with fairly tight budgets going forward. I mean, obviously governments have had to move a lot of funds into supporting people, and ultimately that may lead to some constraints elsewhere in the system. So I'm just wondering if in Canada, provinces and territories, your customers essentially find themselves a little cash strapped. How do you anticipate that affecting your HTA processes, or how will it manifest itself in the way that you do your work?
Yeah, it's a good question. I mean, certainly it's something that, reflecting on a point that Inaki made, I mean, I guess I do feel like HTA will become even more important. The fact that, if budgets are tight, making even better decisions is going to be more important. With respect to what provinces and territories do, I mean, I think they're waiting to find out what's going to happen and as well, right? And how their budgets may be affected or may not be affected. I mean, we really don't know. We haven't had a product come for assessment and have a discussion about, who the payer might be. So I think it's deciding, like, will we get to a point in time where we have to discuss prioritization? Will it come to that? I mean, we've talked about it for years in Canada, because it's not just about the HTA, it's, what happens downstream about sort of the price negotiation parts of it as well. And so, there's already, that's a busy step, and can take a long time. So adding more to that, or do we need to be thinking about, what actually does get assessed? So I think this is going to, prompt a lot of conversations about, how we might do things differently if we need to.
Does
someone else on the panel have a question?
Yeah, I wanted to ask. Thanks so much, Michelle. It's nice to hear from somebody who's actually having to live with it. I'm not quite in that situation, and more ivory tower. But I'm curious about. It seems like, as Matthew said, it's going to put pressures on budgets in other areas like hospitals and so on. And we hear about people delaying elective procedures. But how's it affecting the processing of the drug pipeline? So we've been set up to produce this 30 or 40 new drugs that the FDA and EMA and Health Canada consider every year. Seems like that's got to be crowded out. It seems like that's going to get crowded out too, that you don't have time, you don't have as much time to do your previous job as you had before. So that seems like it'll slow down the adoption of innovations. But do you see any effect there yet or not?
Well, we haven't with our regular business, and again, I think it's how we decide to prioritize at CADTH. So I mean, it's the choices we decided to make to keep our common drug review and our pan-Canadian oncology drug review running. So at the same pace, so we could process and we weren't you know, contributing to any lag time that way. So yeah, those are the decisions we made. You know, if there are more products being added, that's something that we'll have to sort of, those decisions will need to be made, or will more resources get added to the mix, or will CADTH prioritize differently across the organization? Those are conversations that we're absolutely willing to have, you know, in conjunction with our colleagues or with our funders, really.
Okay, thank you.
Right. Well, thanks. I'll pass it now to Lou. Thank you, Michelle. Very appreciated.
Okay, good. Matthew, I see that I have the mouse, but it's a little slow on the. Okay, thanks very much. Again, my name's Lou Garrison. I'm from the University of Washington. Been here 16 years now. I'm professor emeritus now, so I've been in lockdown for like 132 days at my age, so not getting out much, and so I'm more than ever I'm in and I retire, I suppose. I do continue to do work with various organizations and research. From the HTA side, I sit on a private payers P&T committee, which is probably my greatest exposure to what happens there. And I'm involved in ISPOR, and the views I'm expressing are my own, obviously. So just let me highlight what I think are some key messages for me about the U.S. situation. You know, given all the limited evidence we have on testing and treatment effectiveness, and we don't have vaccines yet, so we don't know. Obviously limited evidence, where it's a tremendously uncertain period for HTA, the policymaking environment. And in our country, the polarization and the lack of I guess the second point, the lack of a well-organized federal response has really hindered our ability to fairly assess technology. So we're having a tremendous debate now about whether to reopen the schools, how to reopen the schools, and so on. And that it does, you know, from the standpoint of modeling, that creates a tremendous challenge for those of us who are kind of economic evaluators. I actually worked on a pandemic flu model published in 2009 with an international team, and I remember we modeled, well, what would happen if we closed the schools? And we said, well, the parents will have to stay home and they'll lose some productivity. And so we put in a number. Well, you know, if you're living this, you know that it's a lot worse. It's a lot worse than that. If I have a daughter who has 2 children having to do homeschooling, her productivity is certainly affected. And, you know, for me personally, you know, I can't hug my grandchildren. So that's a big loss. So there are all kinds of complicated effects. And yet we see that, you know, when we look at the examples of the failure of testing in the U.S., all the discussion about hydroxychloroquine and dealing with remdesivir, we see the problems we have with our HTA setup to try to address these challenges. But, you know, and this was kind of my question for Michelle, we do want to, you know, we have to figure out how we're going to deal with this globally. We're all going to be affected by limited supplies of drugs and vaccines, and how does it affect, in the last bullet, you know, how's it going to affect innovation? But I do think, I mean, we're probably going to be, the current inequities that we see in the US and across the world are going to be exacerbated. The wealthier countries and individuals are going to get earlier access, and so that's going to be a problem for the community. For those of you who aren't familiar with the US, we don't have a centralized HTA. This slide breaks down our population of 330 million. You can see that the kind of the biggest group is this employer-based, this is of insurance, the employer-based insurance, 159 million. And again, that's for people under 65. And that's a very decentralized sort of process where each insurer has their own pharmacy and therapeutics committee. They organize the delivery system, so they kind of do their own HTA. Medicare, it's prohibited from using the quality adjusted life year and explicitly considering costs. So that's another part of the fragmentation. We have Medicaid, which is paid for by taxpayers for those who are indigent. And then we have the uninsured here, which is at still 10% of the population. So we have it's obviously very complicated to try to figure out what's happening in all those sectors. Now, as a result of, and this is stepping back more broadly to some work at ISPOR, the last 7 or 8 years, we've seen the emergence in the US of what are called value frameworks. And we had a task force on this at ISPOR, and we talked about, well, what are these, or how are they different? It seemed to be confusing people. So what's going on? We have a task force report that's available on that's available on the ISPOR website. And we did a whole it was a special task force on trying to sort out the value frameworks. And I like to emphasize that HTA, oftentimes we think about it here at what I would call the plan level, that we're trying to decide what to pay for something and whether to cover it in the health benefit package. But if you step back more broadly to health technology assessment, there are really multiple, kind of a cascade of what we call decision contexts. From the regulator who's weighing benefits and risks, that's a health technology assessment decision. Then in the US, the health plan that I'm sitting in has to say, do we want to put it in the benefit package or not? Well, when it comes to medicines in the US, there's a lot of access. So it's pretty much goes in the benefit package, but well, then how do you negotiate it? How do you deal with the price? Well, there's a commercial negotiation with each. And then you still have the problem, well, how do we manage it? And the US is probably famous for prior authorization, restrictions on use, and so on. So we don't manage so much with price as we do with this benefit management. But then ultimately, there's this last decision context, which is the patient. And some of these frameworks are really focused on the clinician-patient interaction. And I would argue that all of these are aspects of HTA from different perspectives. And we need to keep that in mind, even if we're focusing on access at the plan level. Now, you may have heard of the Institute for Clinical and Economic Review, which is kind of our copycat of NICE in the UK. I call it privately supplied regulation. Basically, Steve Pearson and the folks who started it said the US is failing on HTA, so why don't we just start it, and got some private funding and been doing HTA, and I think it's been having an impact. I just put this as their diagram for all the things they consider, and they certainly do start out with assessing clinical effectiveness, but they do end up doing cost effectiveness, and they've done that for some of the medicine, for remdesivir at least. So I would say, this lack of a centralized coordinated response in the country means, we have the highest rates of infection and deaths in the world. The treatments are trying to cope with these local surges. We have surges are straining hospital and ICU capacity, and it's rotating around the country, so it's not being managed well. And but yet it's interesting to me. You hear claims that we're getting better at managing this, and I'm always a little worrisome about learning by doing because of all the biases we have as learners. But I think and I would like to see more evidence, but there are some trials I know, and people are looking at it, and so I've seen there have been some rapid responses to try to generate data. In terms of, I wanted to comment on remdesivir. This was reviewed by ICER on May 1st. Interestingly, they talked about a cost recovery pricing system, which I thought was personally, I thought was a little misleading, given that mostly they've been focusing on value-based price for their existence. And they basically said at $50,000 per quality adjusted life year, based on the preliminary results from that trial, the course of you could justify a value-based price of $490 to $1,100. Then Gilead launched in June 29th, and they had some other data, and they set the price. They actually did two-tiered pricing. The Veterans Administration getting a lower price than the private sector and CMS, even though that's also a public payer. So that's a whole other story. But basically, they came in at this range, and then ICER revised their analysis. And it was very critical of whether you assume that the trend that was seen in the trials toward mortality improvement or better situation, whether you assume that in the model or not, even though it wasn't statistically significant. But you could say, depending on that, you could justify $4,000 to $32,000 for depending on the quality. So it's an active debate, and that's a whole other issue, I guess. And we had this hydroxychloroquine where it was promoted by the president. The FDA has stepped back on it. We keep getting mixed evidence, so I would call that a fiasco. And then we have the U.S. intervening with trying to buy up a third of the AstraZeneca vaccine. So, sort of not really looking globally, looking nationally. Now, one of the things we talked about in our task force was that, yes, there's more to life than the quality. The quality and costs are important, but interestingly, we had a pedal in here called fear of contagion, which, and we all realize now what that is, that we're all living, with fear that we may be infected. And that's definitely lowering our quality of life every day. We'd all be willing to pay a lot per day to avoid that, to get rid of that. And we are paying a lot through taxes and other things. But it does bring out the point that, our usual societal perspective we use in health economics of looking at the medical care sector is really inadequate for a pandemic. Now we have to deal with, what's the cost of a child missing school for a year? What's the, how many teachers might die if we reopen the schools? So I really think, we have to, as a scientific field, we have to look at the evidence, which means we have to do the math. Unfortunately, the policy is not always based on somebody actually having worked through the mathematics. And the other problem is we're constantly getting new information about the nature of this virus and how it affects children differently than adults and so on. So it's complicated. And final comments, Paul Romer, a Nobel laureate, said a long time ago, a crisis is a terrible thing to waste. And the reason it's, it's very hard to make changes to social institutions because of political interests. And, I was disappointed in 2009 when we had the financial recession. We didn't take an opportunity to deal with the growing inequalities in America and the access to insurance problems that we have. So we have a crisis here, and we still haven't worked out how we're going to ration these supplies. I think that these current inequities are going to be perpetuated and probably exacerbated. And I mentioned this point before, but I think we need to keep in mind that we also need to think about international reference pricing and incentives for innovation, and how we're going to pay and incentivize people to actually continue to innovate. We don't want to get rid of that. Economists have argued for a long time that the efficient thing when it comes to medicines is wealthier people value things more. They can contribute more to fund that, and that'll provide global access. So we need to keep that in mind and work towards that. So let me stop there, Matthew. Thanks again for the invitation to discuss with my colleagues here.
Thank you very much, Lou. I'm going to hand it quickly to Inaki to put a question to you.
Yes, thanks for the presentation, Lou. Thanks for the presentation, Lou, and following your question that you have made regarding educational aspects and which are the measures that we are going to take in terms of being back to normality, I would say. But based on the presentation that you have done, it wouldn't be a need to think about the health technology that is related to how to provide universal health coverage in the US?
Yeah, no, that's what I was hoping that in the crisis we would actually try to realize that it's really testing our system because of the employer-based system. When you have millions, tens of millions of people unemployed, then they're not going to have access to health insurance. Okay, and that really exacerbates that. At the same time, because of the polarization in our country, we have the current administration pushing to essentially remove Obamacare and remove that access. So we're very much a divided society at the moment, and we're asking questions until we get past this next election. We're not going to have a chance. We're kind of frozen until after this election, and depending on the way that goes, that's going to affect everything. But there's the opportunity, if the Democrats were to win, that we could start to look more broadly at reforming some of these addressing some of these other social issues. At the moment, we're deadlocked. Thank you for that, question. Yeah. Inaki, in our field more generally, we've pushed for like a broader societal perspective. It seems like, it's almost what I would call general equilibrium, because the U.S. second panel had a big checklist, and they had a whole lot of other sectors that were affected by healthcare, criminal justice, education, environment. And it seems like we're forced into now we have to take a much broader societal perspective. And we're not set up, we haven't been set up to do that so much in terms of the mathematics of working out the models that we have to do. So I don't know if you're expanding your modeling efforts in Spain or
Yeah,
not.
well, yeah, we are considering much more the societal perspective, especially because we are nowadays that we implemented the universal health coverage since the 80s. Nowadays, what we are working it is in a much more integrated system in which we include the social care. So that has brought up needs also to consider the what is the affection of the economy, especially on the side of the social and healthcare, and especially including the cost of the caregivers and the cost of the society. So from that side, I think the perspective has changed, and I think the pandemic has put especially in place this because the subpopulation that has been mostly affected. So it is the aging people and especially those that have critical illness. So those have been the fact.
Thank you.
So I have a couple of questions here. It is that last question around societal perspective. I think that's a fascinating one because a lot of HTA bodies around the world, you know, make the problem tractable by restricting their view to the health sector essentially, and not going as wide as the education sector. So, interesting point. So anyway, sorry, just trying to catch up on a few questions. So there's one question here about the comment on the costing proposals proposed by the ISA white paper. Did you have any further comments you wanted to make on that, Lou? You covered that very quickly. I just wondered.
Well, I mean, you know, okay, honestly, I'm not. I think it was odd for them to introduce this concept of cost recovery at this point when they've been doing value-based pricing all along as the first thing listed. And you know, I don't think I think you can certainly make a case to for like buying out patents and then distributing something at marginal cost to everybody in the world, and maybe you could make that argument. But the question is, well, how much? What are you willing to pay to buy out the patent and then make it available? Now, again, you see Gilead is using tiered prices. They did that in the past for Sovaldi. So the prices were, and that's what economists would argue for. We should have global differential pricing. So we'll have to wait and see. But at the same time, we have such limited supplies now that they're being rationed. And just like everything else in our world, people with money get them first. You know, that seems to be true of the current drugs and everything else. So, but at the same time, we really do need to look more broadly. Now, I think it's just so early on in this experience that basing it on a limited trial and then trying to set the price is not, is a very kind of difficult exercise. And you could argue that actually Gilead underpriced the product, maybe because of some of the pressures that they're under from a public relations point of view in terms of the value they're delivering. But yet we still don't know the value that they're delivering. We'd like, in a sense, we'd say, well, if we're willing to pay $150,000 per quality, then why shouldn't we pay that? But we don't really know how many qualities it's going to deliver, right? And what cost savings are. So there's a lot of uncertainty about that. So we need to have, I think we need to recognize that we need to be flexible and adjusting payments as we learn more.
Right, I've got a second question here, perhaps more generally to the panel. So, as a consequence of the COVID-19, will reinforcement of local HTA analysis change the view on joint assessments, e.g., downgrading its value or deferring its potential implementation? So, I think this, yeah.
Well, I don't think so. At least the response that we are having, especially in Europe, it is, for example, in the case of UNED, there has been a COVID-19 response team in which many agencies we have shared the information. So I think it is reinforcing also the value of joint assessments, especially on the side of some of the aspects that could be shared. Obviously, the local aspects are not going to be implemented, and that reinforces the role of HTA answers in terms of local context, but not in terms of enhancing and increasing the number of joint assessments that we can produce. Similarly, there have been also coordinating actions at the level of the society, HTAI. We have also a response team about that. We have recently discussed about those things, and I think we need to bring clarity to those that are going to make the regional or national analysis. In principle, given some kind of standards and rules that they can follow, and also agreeing on which are the evidences that they are going to implement. But I think it is reinforcing both values. On the one side, it is the importance of collaboration, and on the other side, the importance of sharing information. And I think it is both.
Yeah, maybe if I can just add to that, you know, perhaps not from a joint production point of view, but just from a collaboration, I think it's only increased during this time. You know, we had good collaborations already within Canada, but you know, we've really certainly enhanced that with Ines, our counterpart in Quebec, and also with our regulator. I'd say that with Health Canada, conversations have been very good, but also other HTA bodies around the world. So we've had, you know, non-product specific discussions, but discussions with NICE, with PBAC, with SMC, as well about, you know, kind of COVID response, and with INATA as well, the international network. Certainly they also have had a response in terms of sharing what others are doing. So, you know, there might not be a need to duplicate, especially in parts of the world that have less capacity and, you know, might be struggling more. So how can we help out?
We've got just a couple of minutes, and I know there's one among us who has a pressing deadline and will leave exactly at midday. But I just want to ask, this is an interesting question, I think, and perhaps get a 2-second response from each of you. Can HTA methods help advance the national conversation around how to help with response and recovery of the economy? So that's a very broad HTA kind of a question. So thoughts?
Well, let me just, I do need to run, I'm sorry, to another webinar that I have to talk in a second. But I would just say that I discovered that some of our colleagues who'd evaluated vaccines in the UK had done something called a computable general equilibrium model, which would look at the economy. So I would just say, yeah, we have people doing HTA that look at general equilibrium, look at all the sectors. So, you know, we don't do it routinely in healthcare. We focus on the healthcare sector, but some people from our field are looking that way, and I think we have to broaden to those perspectives. Just like in that model I mentioned, we had to think about what was the cost of school closure. So we do need to do that, and I think we can do the math. We need to do the math, and we get and assemble the evidence. So thank you for hosting this. I need to run. Great to see you, Inaki and Michelle.
Thank you very much, Luke.
Yeah.
Any comments from the rest of you?
Yeah, on my side, I think definitively yes. I would say that as Michelle has said before, I think one of the things that has put in relevance the pandemic, it is that HTA it is more needed than ever, and especially it has been very valued for at least in our experience with innovators, especially in guiding them. And I think it has been crucial for systems to take fair decisions on the one side, especially on deciding on which treatments to use and which diagnostics also to be purchased. But on the other side, I think it has been crucial in terms of guiding the innovators, in terms of bringing their products to the market, and public-private collaboration. I think it is very important, and HTA could play a nice role.
Yeah, and for me, I would say, HTA is full of talented people, whether that be sort of from an agency perspective, but also from industry, patient groups, decision makers. It's about putting those skill sets, to work and addressing the questions that need to be answered, but making sure that they have the tools available to them to do it. I think, we were pushed outside of our comfort zone for these, and obviously some of the approaches that we had to take have had limitations, but could we do something different? For example, this might be as simple as having access to certain databases, so we're sure that sort of the capture is appropriate. But yeah, in terms of the talent, I think it's there, and I think HTA is well positioned to assist.
Interesting. Thank you very much. I'd like to thank all of you for agreeing to be part of this panel and put forward your thoughts on the question that we've had here today. Very interesting. Obviously, everyone has to adapt very quickly, and I think the interesting elements that will come out of this is that hopefully there's be some good changes as a result, and be able to move the HTA science forward as we, progress out of this, hopefully out of this, and this situation. So thank you very much for being a part of this, and I'm going to hand off now to Suzanne.
Thank you so much, Matthew, and thank you so much to our speakers, Inaki, Michelle, and Lou. Had a great discussion here. Before concluding the webinar, we have a few short announcements. On July 23rd, Dr. Jaap Mandema will present model-based meta-analysis for comparative safety and efficacy of therapeutics for COVID-19. On behalf of Certara, I would like to thank you for attending today's presentation. This concludes the webinar. Goodbye and have a great day.
Yeah, thanks, Matthew, for conducting this vivid discussion.
Pleasure. Thank you for joining us.